So as all of you know, burden of cancer is increasing in our country. The non-communicable diseases like diabetes, hypertension and cancer, they are taking the center place. The cancer incidence is increasing due to increasing population and aging population because of increased life expectancy, increased tobacco consumption and newer infections. Like 30% of the cancers are caused by viruses and bacteria, environmental pollution, and faulty dietary habits, and finally, it's a lifestyle disease. Like diabetes, hypertension, and cardiac disease, even cancer has become a lifestyle disease. The significance of early detection is if you diagnose cancer in a first or second stage, then it is cured in more than 80% of the cases. When the diagnosis is made in third or fourth stage, the cure rate drops to less than 20%. Not only that, the treatment is less mutilating and economical in early stages, and the treatment burden is less. Maybe the patient can be cured with a single modality instead of multiple modalities. As you know, the carcinogenesis, it is genetic susceptibility and immunosuppression on one side, carcinogens acting on a cell to make it a cancer cell. Briefly, the carcinoma starts in a single cell, then it becomes non-invasive cancer, then an invasive cancer, and finally it's a metastatic cancer. When we look at the early detection, there are two methods. One is screening, that is looking at the asymptomatic population, and early diagnosis in symptomatic individuals. So this is the brief interval. The symptom onset, if you do screening before the onset of symptoms, we have got the general population screen and early diagnosis made. But once the symptoms are made, again you can make early diagnosis and cure them better. A word about screening. Examination of asymptomatic individuals for early detection of disease or its precursors is screening. But as far as cancers are concerned, very few cancers are amenable for screening in general population. The reasons are, in any screening we have bias, what is called lead time bias. You can look at this. Without screening or with screening, the patient is going to die at the same age. But because you have screened and detected the cancer early, apparently the patient has lived for more time. This is what is called lead time bias. Comes to length time bias, the cancer is not one disease. In each organ, now we have molecular classifications where the cancers are of different virulence. We have got at one extreme, extremely benign cancers, other extreme, extremely virulent cancers. Like in breast cancer itself, we have got what is called luminal A, where excellent survival is there and many patients live without treatment for long. Whereas in the other extreme, we have got the triple negative breast cancer, which has got very virulent course. When you do screening, these less virulent cancers are diagnosed more. It gives apparent increase in the lifespan without there being any real benefit. Then we have got that overdiagnosis benefit. Sometimes many cancers are there in the body, they never manifest, and finally the patient dies of other causes. A classical example of that is prostatic cancer, where at the age of 90 years, more than 90% of the patients, if you do a serial biopsy of the prostate cancer would be there. We are overdiagnosing it. We'll come to that later. So you look at this, in the screen group, 3 cancers are diagnosed, only 1 died, that is 33% mortality, but natural death is at the same time. The unscreened group, only 1 patient is diagnosed and that patient dies. Again here you look at 100% mortality, but it is not true. You are unnecessarily detecting cancers which are never going to be apparent. So this is what is called overdiagnosis bias. Not only that, screening leads to overtreatment, anxiety for the patient, and also cost. Looking at all the aspects, what happens is we have got randomized clinical trials where we don't look at the reduction in mortality. It's overall. You compare 2 groups like 2 villages or 2 cities which have been randomizedly allotted to one screening or the non-screening. We look at the overall mortality from the cancer. Thereby, we come to a conclusion whether screening is useful for that particular cancer or not. Based on that, Screening for general population is recommended only for 4 cancers. One is the cervical cancer. As we know, cervical cancer has got a definite etiology now, that is the HPV-induced cancer. It has got a long pre-cancerous stage in the form of different dysplasias for 10 years before it becomes invasive cancer, and gives us a great opportunity to diagnose the precursors and prevent onset of cancer and also cure it. And then the breast cancer, the oral cancer and the colorectal cancer. These are the only cancers where recommendations are there for general screening. So for cervical cancer, it is 21 to 29 years. Onset of screening at the age of 21. Pap test every 3 years. No HPV testing up to 21 years. And then 30 to 65 years, either do a co-testing every 5 years or only pap smear every 3 years. Thereby, we can detect precursors and treat them with good cure rates. In breast cancer screening, 20 to 39 years old, monthly breast self-examination, and 40 to 49 years, monthly breast self-examination, yearly clinical breast examination by a professional, and mammography every 2 years. Between 50 to 65 years, up to 69 in some recommendations, monthly breast self-examination, yearly physician examination, and yearly mammography. It is going to detect most of the cancers in early stage where we can cure with single modality. Then oral cancer, it is specific screening for Indian conditions. Here just a visual examination of the oral cavity and palpation of the oral cavity, where you can feel any thickening in the oral cavity, any ulceration in the oral cavity, leukoplakia, erythroplakia. They are diagnosed and the patient can go testing. The colorectal cancer is another cancer which is amenable for screening in Western countries. Even in Indian situation also, the colorectal cancers are increasing in incidence, and it is time we also have a regular screening program for this. The fecal occult blood test every year from 50 years onwards, a diagnostic colonoscopy at that age, then annual fecal occult blood testing, and every 5 years flexible sigmoidoscopy, and every 10 years colonoscopy will detect pre-malignant conditions like polyps. Again, colorectal cancer has got a long precursors, like you got adenoma carcinoma sequence. It takes 5 to 10 years. So by detecting these polyps before they turn malignant, we can cure most of them, will prevent cancer occurrence. So these are the only cancers amenable for regular screening. It comes to some other cancers. There are recommendations to screen the high-risk population. One is lung cancer, ovarian cancer, and the pancreatic cancer. The lung cancer screening criteria at 20 pack years, that is a person who smokes 1 pack of cigarette for every day for 20 years, we call 20 pack year. Those who have 20 pack year usage, who are current smokers or who have given up smoking less than 15 years ago, should have annual low dose computerized tomography of the chest annually from 50 years onwards to up to 80 years, and it has yielded results, and it is one of the current recommendations. So it is only for 20 pack year smokers. And then ovarian cancer, it is a cancer which is usually diagnosed late, but unfortunately in general population we do not have effective screening tools. But in a particular subset of individuals with strong family history, where one first degree relative or 2 second degree relatives have ovarian cancer, or those with BRCA mutations, they should undergo ultrasonogram of abdomen, pelvis, and transvaginal scan, CA125, and clinical every 6 months to 1 year. And the screening should start 10 years before the onset of the index case. But the evidence is low quality. Next, pancreatic cancer. This is one cancer which is a silent killer. Most of the pancreatic cancers are detected very late, and most of them are incurable. In these, certain conditions like family history and another interesting recent onset of diabetes and BRCA mutations, they are screened annually with endoscopic ultrasound, MRI, and screening should be started 10 years before the index case, and it is also has got a low quality evidence. Interesting thing is some screenings were recommended and then abandoned. This is because of, again, we talked about the bias, detecting unnecessarily cancers which are never going to manifest. A classical example is prostate cancer. Once there is a lot of stress on PSA examination, but now that is given up. What is recommended is a physician should never recommend PSA testing for any patient, any individual. It is not a screening test. But the individual wants to get it done, you can recommend it, but we are not going to tell them get PSA done as a screening. Another interesting is the thyroid cancer. This has happened in South Korea. They had a screening program. Once the screening program started, they are detecting more and more thyroid cancers, papillary cancers, which are less than 1 centimeter. And then the surgery rate has gone up by 80%. 8 times surgeries they are doing, and suddenly they realized that they are unnecessarily doing surgeries on cancers which are never going to get manifested. So they given up the screening program. In India, the government program includes the 5 diseases are getting screened. One is diabetes, other is hypertension, and 3 cancers, cervix, breast, and oral. The cervical cancer is by visual inspection and visual inspection after acetic acid painting. Then breast is done with palpation by health professional and oral by inspection by a health professional. This is very cost effective. It is not going to detect precursors, but it is going to help our population. Something is better than nothing. When it comes to the early detection, it is by early diagnosis. The early diagnosis is by heeding to the early warning signals of possible cancer. You got this? Be cautious. Bleeding or discharge that is unusual, extraordinary loss of weight, cough or hoarseness that persists for more than 3 weeks, a sore that does not heal, unusual change in bowel habits, thickening or lump in breast or elsewhere, indigestion that persists, obvious change in a water mole, unexplained loss of appetite, and some difficulty in swallowing. This mnemonic, be cautious, should be remembered. Most of the times, the symptoms should resolve within 3 weeks. The symptoms persist for more than 3 weeks. We have to investigate what is the reason for the symptom and then make a diagnosis. It need not be due to cancer, but investigation and diagnosis becomes important. So these are the problems we face. The first symptom, there is access delay. The patient who is having the symptoms, they take time to come to the physician. But more important from our point of view is the poor performance and referral issues. Many times the physicians, they don't diagnose that it is due to cancer. The classical example is rectal cancer, where the classical saying is, if you don't put in a finger in the rectum, we'll put our foot into that. So most of the times the bleeding rectum is treated as piles until the patient develops advanced symptoms. Many times it happens that the patient is attending physicians, but awareness of the physician also is very important. Once the diagnosis is made, then we have issues of waiting lists, suboptimal resources, all those things. And there are financial barriers from the patient point of view, logistical barriers, and because there is a lot of distance between the patient's native place and the treatment center, psychosocial barriers. People don't want to get diagnosed with cancer, so they avoid coming to the hospital. So all of these are creating problem in early diagnosis. The best would be in cancer primary prevention. 50 to 60% of the cancers are preventable. As we said, the cancer is a lifestyle disease. These are the main causes. We know tobacco, alcohol, viruses. Cervical cancer is due to virus. And then hepatitis B, HCV, and liver cancer association. And diet is very important, esophageal and gastric cancer as well as colorectal cancers. And other things are less important. So the primary prevention is by a cancer-free lifestyle. Avoid tobacco, moderate alcohol intake. Now the recommendation is changed to no alcohol intake. Balanced diet, like carbohydrates, fats, and proteins in proper mix. Safe sex to avoid the sexual transmission of viruses. HPV is sexually transmitted, HIV is sexually transmitted. vaccinations against the infectious agents causing the cancer like HPV vaccine for both cervical cancer and penile cancer, and hepatitis B vaccination, etc. Physical exercise, mental relaxation, avoid unnecessary exposure to chemicals, drugs and radiation pollutants. That will lead to a reduction of 50 to 60% onset of cancer itself. Fresh fruits and vegetables containing vitamins, avoid salted, smoked, fried, fast, high-fat, spicy foods. All the current food fats, they should be avoided. And then there is surgical prevention. If you see some conditions which are likely to end up in cancer, do surgery and treat them. Chemo prevention under investigation, nothing is proven except the tamoxifen in breast cancer. So to conclude, 25 to 30% of the cancers are amenable for screening. Most cancers can be diagnosed in early stages if early warning symptoms are adhered to both by the patient as well as by the physician. But 50 to 60% of cancers are lifestyle related and are preventable, and our stress should be on that. Thank you.